A very good morning, everyone. On behalf of AFG, the office bearers, and the conveners, I welcome all of you to this unique hands on workshop on invasive prenatal diagnostic testing. I would like to, before we start, I'd like to welcome our president, Dr. Anurag Bhate, to give his address.
Hi, good morning everybody for this fetal medicine workshop. AFG welcomes you all on this Sunday morning. Apologies, we had a slight glitch with the MacBook issue, but I think it is solved and we are on with our first talk. So everybody, I welcome you all on behalf of AFG.
I would now like to welcome our convener, Dr. Raju Sahitya sir, just to address our audience and talk about this program a little.
Good morning, everyone. Why don't you come in front and occupy the seats here? So you will all agree that in this inverted pyramid of prenatal care, after screening follows invasive prenatal diagnosis, and we are here with a very targeted program. It's going to be lectures relevant to invasive prenatal diagnosis, followed by the hands-on training on specially designed mannequin and simulators, and I wish you all the very best and be there till the end. I'm sure following this you will be able to go and do your procedures yourself. Thank you.
Thank you so much, sir. So we now begin our sessions. I would like to welcome our chairpersons for the first session, Dr. Shalini Agarwal. Madam is the founder director of Dr. Agarwal's Women Health Hub Santa Cruz East and a consultant at Neeron Hospital, Surya Hospital and Guru Nanak Hospital. I'd like to welcome Dr. Saurabh Surekha. He is a young dynamic freelancing laparoscopic surgeon with a special interest in advanced lap and hysteroscopy. He is a consultant at Anand Mother Child Hospital and a managing committee member of AFG. So now over to our chairpersons.
We would like to call upon the first speaker for the day, Dr. Vandana Bansal. She is professor and head of Department of Ultrasound Department, Vardia Maternity Hospital, St. J.S. Medical College. She has super specialization in fetal medicine and interventions. She is the first postdoctoral fellow of National Board in India, qualified in high-risk pregnancy and perinatology with 28 years of experience in obstetrics and 23 years in fetal medicine. Over to you, ma'am.
So very good morning to all. I am here to start the program. So I think I'll start off a little basics and then we will go on to the procedures and then the complications, then how to do it. So first of all, topic given is on amnio and CVS. So we all are obstetrician probably, and what we do is normally we screen all our patients. Earlier we used to screen only the patients who were old in age, but now we have started doing first trimester screening, as what Dr. Raju just said, that we do screen for all and then we come on to having something positive where we need to do invasive testing. So basically when we do these screening tests, which are, as you all know, of combined first trimester screening test or a quadruple test that we do in the second trimester, there will be reports which will come as positive, and there is where we will need to do invasive testing on this. We also have these soft markers which come up, and you may have a screening which is good, but a soft marker may change your likelihood ratio, and probably then again there might be a requirement for an invasive testing. So these soft markers, you all know, the ones which are very significant are this ventriculomegaly, nuchal fold, hypoplastic nasal bone, and ARSA. So, and now we have an NIPT. So this is one which has got a very good diagnostic screening test, but the problem is that it may also come as false positive, and you can't just think that I will do an NIPT and be over with it. Sometimes they will come as positive, and then again you will need invasive procedures for that. So this is a very good test, but it has to be used correctly when you are doing that. So what we were doing earlier were this. We have this screening test done either first trimester or the quadruple, and if the risk was less than 250, would do an invasive procedure, and if it was more than 250, we would leave it and say it is low risk. So this was the cutoff that we were using conventionally. So you could still continue to use that, because lots of labs are still using this, that as soon as the 250 ka cutoff, they will write it as high risk, and if it is more than that, they will call it as low risk. But if you want to read between the lines, then this is a new concept which is there, that if the scan is normal, whether it is NT or it is anomaly, then we will call it high risk if it is 1 in 100, and if it is 1 in 100, we do an invasive testing, and if it is 1 in 1000, we call it as low risk. And the ones which are between 100 to 1000 are the ones where we might need an invasive testing. But here we could do an NIPT if in case the scan is normal, and NIPT will take away a lot of our invasive procedures. And if your NIPT then comes as high risk, then we need to confirm it by an amnio or CVS. And if it is low risk, again you can leave it. So technically this test is giving us more accuracy also, because if it is risk high, we are doing a test, and low risk, we are not doing a test, and we are not doing too many invasive procedure, because that NIPT is helping us to triage them into the ones where the NIPT is low risk, you can leave it, and where the NIPT is high risk, do invasive testing next. So this background I brought in is because we are going to talk the whole day on invasive, so where we want to do it is what we need to look at. So this is a data international, where you look at all the structural abnormalities, and every one of the anomaly has got some genetic abnormality. So not that anything which we do, if it is cleft lip, it is not associated. Every disorder, cardiac, limb, urinary, nervous, digestive, all will have some genetic abnormality. So now the guideline is, you have a structural abnormality, you need to do an invasive testing, whether it is a basic clubfoot or cleft lip also. And there is always this overlap. When you have one anomaly, look at the heart. Echo is important. If heart has a problem, you need a genetic. So this overlap means you have to do a anomaly scan, you have to do an echo, and you have to probably do an invasive testing also. So this is how I look at it is, if I see a malformation, I'll find out whether it is lethal or morbid. Is it compatible with life? Am I going to tell the patient to terminate or not terminate? Whether it is associated with any other abnormality. Plus, is there IUGR? Because if there is IUGR with abnormality, again more chances of genetic problem. And then we need to do a genetic test on this. So with this background, and if I continue, then we would how to follow, where to follow, that some other conference will do, but more on the invasive things now. So with that background, that we have done a screening test. Now something comes positive, then what do we do? So we know fetus is like a patient, we have to, mother and the fetus is there, and the ultrasound is our hand, which we palpate the uterus. That means we look at the anatomy, we look at the function of the breathing and everything, and also the physiology and the pathology. So similarly, now the fetus has to be tested. So if there is a disorder, I want to test the fetus, and that testing is what is invasive testing. So we could do this testing for genetic abnormality, for some biochemical, hematological, or sometime even a skin biopsy also is required. So what test to do when will depend on, one, what was the disorder that we are starting off with, what is the gestational age for it, and what are we looking for. So if it is something to do with blood, then I want to do a cord blood. If I am looking at skin disorder, I will do a skin biopsy. If I look at genetic problems, then I would do maybe an amnio or CVS. If it is early weeks of gestation, it will be CVS. If it is later in gestation, I will do an amniocentesis. So that is how, what test to do we will see. So we have on our This is our CVS being done. So you can see that needle inside. So this CVS is done between 11 to 14 weeks. If it is something to do after 15 weeks, then I will do an amniocentesis, that's the baby and that's the liquor, and the needle will go into this area and we can do an amniocentesis. This can be done after 15 weeks, not 20 weeks, but you could do even later on if required. And third is if we have some hematological disorder, although it's not part of this, but I would still say that we may sometime need to do a cord blood sampling also here being done. This is the needle in the amniotic fluid and in the placenta. So of all of them, the most common is our amniocentesis, but yes, we still do a lot of more CVSs nowadays. So we've taken out a sample now, what to do about it. So what to do has to be decided before only. You can't take the sample and then say, I don't know what to send for, let me talk to the geneticist. So your plan should be ready before you're doing the invasive procedure. So we would have a menu like how we have. What do we want to do is something which is chromosomal. So you have got either a routine karyotype, you have a FISH QF PCR, and you have a microarray. So these are for obstetrician, just to understand chromosomal menu. Then your chromosomes are not going to tell you your single gene disorders, something like thalassemia, or you will have to specifically do that. So for a single gene, you either have a whole exome, which is commonly being done, or it is Sanger, that I already know which gene I have to look for and I target that gene only. So that is a target testing, and that is called as a Sanger. And there are certain things where we do MLPA also. But for you to remember, you have FISH karyotype microarray for chromosomes, and you have a whole exome. Earlier we used to do clinical, and a single target is your Sanger sequencing that you would do. So karyotype microarray, which one better? So karyotype tells us about the bigger chromosome. Microarray tells us about even the deletions and duplications in the chromosome. So nowadays, if it is some structural abnormality, it is better to do a microarray. The cost is slightly high, but it is the standard of care now all over the world and in the guidelines. So now with this little background, let us now go to when do we do? So either there is an increased risk for chromosomal abnormality, then we will do, or there is an increased risk for a genetic, that means single gene disorders, where we will do, or I suspect there is a fetal infection that I want to test. So basically 3 reasons: chromosomal, genetic, infection is why I want to do. So chromosomal what? First, if I have a screening test positive, as I said, first trimester screening is positive, or a quadruple test positive, or I find some soft marker like an absent nasal bone, then I will do, or an increased NT I will do. Or if there is a big structural defect, duodenal atresia or something where you think it is correctable, but let me look at the genetics. If it is normal, then we will do. If a previous baby has got Downs, or previous baby has a genetic problem, or the parents are balanced translocation. So these are the indications for chromosomal. So I will do in all of them FISH and microarray, or FISH and karyotype. Then we would do for single gene when there is an increased risk for single gene disorders. What will be those single gene? Either the parents are carrier for some autosomal recessive. In consanguineous marriage, we will have 2 genes which are present in both, so they are carriers for it. Or a child has been born with a genetic problem, or there is a family history of multiple parents and the children having a genetic disorder grossly. Or as I said, infections that I see on ultrasound, some markers of infection I will do. So 3 reasons: chromosomal single gene infection, chromosomal any screening positive or structural infections if infection present, and single gene disorder if there is in the family. So the guideline, as I said, for anything, if I see the structure is normal but there is some screening positive, you would offer them a CMA or a karyotype. Karyotype, okay, if everything is normal, but microarray is a good option, but if cost is a concern, karyotype. But if there is an abnormality in the scan, if there is any markers which are seen, then it is better to do a microarray directly. If I feel that it is definitely Downs, then I will do a FISH and see. If fish is downs, I'll do karyotype. If fish is normal, I'll do microarray. So microarray is where you want to do. But if it is looking like downs, then you may just do karyotype. So our own data, this was internationally, people were saying this is our own data, my own publication of the highest number of invasive procedures been done. So NT, almost 19% had some aneuploidy, big number. So NT, don't leave it on NIPT, NT needs to have a invasive testing. Then we looked at structural anomalies. 11% had abnormalities. So again, structural abnormalities, don't leave it on NIPT. FGR, lot of them died when there was very early FGR, and they had aneuploidy of 10%. And absent nasal bone, again 16%. So it's a huge number. These things, if you see, you can't leave it for not doing, and invasive testing will be required. So now coming to our invasive, what center, what recognition required. So we need to have a center which is registered for invasive procedure. Then we should have, the procedure takes 2 minutes, the counseling takes 1 hour. So the counseling is more important because you need to first tell her what is your options, what is to be done, what you are going to do, what are the risks involved, what are the benefits, and what are you going to send for. So all this has to be done before you put in a needle. Needle will take 2 minutes, Raju sir, PRS madam will do it in minutes, and I will do in minutes. But the counseling will take us longer time, and the patient has to be ready for it. Then after that we take a PCPNDT form F, and G is for the invasive one. A good scan is done already, and a blood group is what is required. Yes, other things may be done as a routine, but blood group is what required because we might need to do an anti-D after that. So now coming to amniocentesis, we will do between 15 to 20 weeks. So you will see where you don't have a part of the placenta, and you know this is a good pocket that you have. 20 or 22 gauge needle can be used. It can be done between 15 to 20, not before 15 weeks, because before that you could have problems, and the cells may not culture, and they can be limb reduction defects. So you have the needle in the amniotic fluid, and then under vision you can take out fluid. So how much? About 20 ml of fluid is to be taken out. If it is Rh negative, anti-D to be given. So what are we counseling them on the risk? So either the procedure related risk is only 0.1 to 1. It's not huge. Whatever comes to us, बोला था amnio करने में बहुत risk है. So the risk is 0.1 to 1. In our study of those 500, we had not even one case. So our also results, you can say 0.1 to 1. Very small risk of leak, which can also seal. So leak, if it is there, conserve it. You keep her on bed rest, it will seal off. This is a nitrogenic leak, it will seal in most of the time. Very rare chorioamnionitis and very rare culture failure rate in procedures. So yes, I said not before 14 weeks amniocentesis, because loss rate is higher, talipes more, even respiratory morbidity more. So which needle to use? 20 or 22, both are okay. The literature also says you can use both. I use 20 in Vadia and I use 22 in Surya. Both have got similar results. So using what needle doesn't matter. 22 has a problem because it takes a longer time to pull it out. So maybe that is there, but the pain is little less. So both can be used, both have similar results. So what are the risk of amnio? Who will have more? One operator is the first thing. You need to have lots of procedure done and continue to do them more. More than 2 attempts, the risk is slightly higher. If there is a structural abnormality, then the risk anyway is little higher, and you doing an amnio may increase that risk. And if there is a bloody tap, that means there is some prick or it is a chronic infection, there is a mixed blood, there is a chance of a miscarriage slightly more. Do not go through the placenta, not near the cord, and not through the thick part of the placenta. If not, then go from a side, from as close to the thinner part. This is one I brought about is, this is an old blood. This all is usually old blood which was there. These will not culture. So be careful. If you have something which comes out like this, then send for a microarray better, or your fish is going to tell you the culture will not grow. So you need to tell the patient this is how the blood liquor has come out, this will not grow, so send for a microarray. There also contamination is possible, so problems with that. So now when I have this amniotic fluid in my hand, they are sent to the lab, the lab will culture it and then will analyze it. So usually karyotype takes about 3 weeks, microarray 2 to 3 weeks, different labs. Mutation, if it is single mutation, you come get a report in a week's time. But if I want to do a whole exome, then again it takes 3 weeks. And QF PCR or FISH is an early report for us to tell us. So both of them are okay. The technology is different, FISH and microarray, but FISH and QF PCR, but both are telling us 13, 18, 21 and XY chromosomes. So now coming to CVS. Again now CVS is done between 11 to 14 weeks, not before 11 weeks and not usually after 14 weeks. The amount of tissue is written as 10 to 25, but how do you weigh it to find out what it is? So it is just visually you look at. So CVS before 10 again is associated with limb defects and facial defects, and this is how the CVS is being done here. Through the placenta, we don't go into the liquor, we have to take it. So anterior also, posterior, and Dr. Raju is going to show us a posterior transcervical one. So you can either do transabdominal or you could do transvaginal also with this cannula. You have these specialized cannula which you use. I leave it for Sir. Sir is expert for that. So now for our problems with CVS. Now as we used to say that CVS is more riskier, amnio is better, the CVS also the results have come out and the risk is almost same, 0.2%. I find CVS is more safer because I'm not going into the sac only, I'm not puncturing the amniotic membrane, I'm only going through the placenta and out. So amnio will have slightly more CVS, but the technique is more difficult. Person doing it has to be better for this. Small risk of vaginal bleeding is there. Small risk of leak amniotic fluid, more from transvaginal. Culture failure is slightly more than the amniotic fluid, and there is a very small chance of a placental mosaic. That means placenta was different from the fetus and you may get a different report. So as I said, grams I can't weigh it, it is just looking at the tissue, and if I see so much of tissue, that means it is okay and this is enough for a sampling for any of them. So the testings are similar, we could do that. So now what is the advantage of CVS? One, we found out the problem early, so I want to find out the diagnosis early so that termination is early. Karyotype is slightly faster because these cells are better. The DNA sample is more for single gene. So if you have thalassemia or something, you have a child who has a problem, CVS is better because the tissue is more and so they can be cultured more and you get a report more faster and the cost is slightly lower. So after the screening, NIPT availability procedures all have come down, but still the CVS is rising because we have lot of more things to test now. So if I have an NT increase, I will do a CVS. If genetic tests we have so easily available, so any brain disorder in the child, we will test it and find out. So I just looked at 1 year of our cases. The CVS was 33%, amnio was 49% and cord was 8%. So almost similar amnio and CVS was only mostly for single gene disorder or if an NT was increased or a screen which was positive. So even our data also says CVS is still going to be there and amnio also going to be there. So risk factors are almost similar, that it has to be done by a good operator, and then the number of attempts should be less. If there has been a vaginal bleeding, there can be problems, structural abnormality again, and even a low PAPE will also have similar problems. So I think cord I will leave and come to twins now. In twins also we have CVS and amnios required to be done. Before that, 2-3 things which are very important is, one is the dating has to be correctly done because we need to do it after our 12 weeks of gestation. Second, the chorionicity is very important to do because if I am testing one, whether it is monochorionic or dichorionic, it is important to look at. For a DCDA, the genetic material is going to be different, but for MCDA, the genetic material is going to be same. So here there is a DCDA twin, one baby looking perfectly normal, and the other one had an absent nasal bone, increased NT, and echogenic focus. So we know one baby probably may have a problem. So both babies, it is a twin peak sign seen, so I know it is DCDA. I will test one from here and one from here. So here you can see that is the needle going into this placenta. It has to be on the side of the membrane and on the side of the cord also. So this is one needle inside, and other one is here on this side. So you have to test both of them and send it, because it is DCDA, different genetic material, and one came out as trisomy and one was normal. So one more important thing is to label these twins, because now when we get these reports, I have to be sure what I have done earlier, which sample was done for which one. You could do a reduction of the wrong twin. Here, because NT was increased, maybe not so, you would still want to see it, but labeling is the other thing which is important. So here for this DCDA, this was an abnormal twin which we reduced. For monochorionic twins, this is again an MCDA, low res primigravida, herself a doctor. One had omphalocele and a single umbilical artery, and the other one had an increased NT and AVSD. So different presentation in an MCDA. So here when they are different presenting, it may be better to do both the babies, because one may be late after fertilization, it might happen. I'm finishing in a minute. Time. So here we tested both of them, and both of them were trisomy 21. So when they are discordant anomalies, even in an MCDA, better to test both of them. Here unfortunately this doctor had both babies trisomy and had to be terminated. So very important to do labeling. So you have to see left, right, but that may change by the time the report comes. So you need to say left, right, placenta, cord, everything all together, and this labeling will be important, especially when here both the NTs were normal and the screen came as intermediate risk. So for twins, one more important thing, worry about this intermediate risk also. Don't do an NIPT, DCDA twin. It could be one baby abnormal, one normal. NIPT is going to give you common report. So here for an intermediate, normal NT, we did a test for her, and one baby was normal, another trisomy 21. So even with an intermediate report, normal NT in a twin, be little careful, because there could be one baby abnormal and one baby normal and can have this. So I think my time is over. So last one case of primigravida IVF, tetraploidy of one of the twins in a CVS sample. So CVS sample, she came for a reduction, and the karyotype also showed 4 of each of them. But scan didn't show much. It was single umbilical artery only. So tetraploidy cannot be a living fetus at 12 weeks. Tetraploidy will always be missed abortion. So question these reports. And so we did an amniocentesis and it came normal. So this is a case of a placental mosaicism. So the fetus was normal, the placenta was abnormal, and that is why that tetraploidy came. So in a CVS, little worried about placental mosaicism. If there is something which is not tallying with your structural reports, then do an amniocentesis. So this our own data. The number of invasive done were majorly for chromosomal, less for genetic. Of all those chromosomal, the true positive is 6% only. That means screen comes positive, don't tell the patient to terminate. Screen comes positive, do an invasive test. The chance of it coming positive is 6%, not screen 1 in 100 or 1 in 200. Or the chance of it coming positive is only 6%. 94% will come normal. But if you have genetic disorders in the fetus, especially these fetuses are sometimes not tested, death happens, some investigation done, don't know what happened. Child is alive, not evaluated. Evaluate these children, find out the disorder, then test that baby, and that is what is required. So where there is a genetic problem, evaluate the index child and work on it. That is how, and the invasive procedures are very safe. And if they need to be done, it should be done. If it is not indicated, maybe an IPT can be done. So I finish here.
Dr. Purnima Satoskar, Madam. Madam is having MD, DNB and FRCOG, consultant at Jaslok Hospital and Research Center, former professor and head of unit in GS Medical College and Wadia Maternity Hospital. Madam is a chairperson at AICC RCOG West Zone, secretary of Indian Society of Prenatal Diagnosis and Therapy, and president Association of Medical Women in India, Mumbai branch. And she is a recipient of Har Gobind Fellowship in Fetal Medicine at Birth Israel Medical Center, Harvard, Boston. And she has published over 40 papers in national and international journals. Over to you, Madam, for.
Thank you so much for the kind introduction, and let me congratulate AFG because it's a wonderful initiative to have such a niche conference on invasive procedures. So I'm going to talk about what difficulties we encounter and the risks and the complications, some of which will be a repetition, but just bear with me for that. Yeah. So the general risks for all three procedures, we are talking of CVS, amniocentesis and cordocentesis. Very occasionally you will get a vasovagal syncope, but usually the patient is supine, so we don't see this very commonly. That is the same thing with any kind of injection which you can have. You may get intrauterine bleeding while you are doing the procedure. For this now, as we know, many patients are receiving aspirin because of the screening for preeclampsia and other disorders. So we have to take care 3 to 5 days before the amniocentesis. We tell them to stop the aspirin, and 24 hours before the procedure, they must stop the low molecular weight heparin. So, and as Vandana was saying, we look carefully to avoid the vessels. Very often, very close to the edge of the placenta, there will be vessels. So there should be a little gap between the edge of the placenta. When you are going obliquely, although you intend to go far from it, you may reach very close to the edge, and that is when the bleeding often happens. Of course, there can be infection. So as fetal medicine people, we always paint and drape and do it with great aseptic precautions because we are used to all the surgical protocols. RH isoimmunization is possible, so the blood group should always be known, and we have to give a dose of 300 micrograms of anti-D. And fetal loss, which we will come to a bit later on. So let's look at them one by one. What are the problems you can face with chorion-villus sampling? When you are doing the sampling, sometimes you will find that no material has come. So that's what we call a dry tap, or the sample may be inadequate. So you can see here, so roughly 20 to 25 milligram is required. So this is just by eyeballing. So this actually we need a little more than this. We don't get so less. We get better, especially now that we are doing it after the NT scan. So this is probably a picture of something we used to do earlier at earlier gestations. Now they are little more branched and you get bigger villi. But by looking at it, if you feel that it is insufficient, for example, if it looks like this, then you may need to do one more pass. But you have to look at it very carefully and try and think why you did not get the sample. And only if you are sure that you are going to get the sample, then you do the pass, because otherwise if you do repeated passes, the chances of miscarriage will increase. There can be an inadvertent entry into the amniotic sac. Now this is actually not a picture of CVS, but just for demonstration purposes. Very often what happens is, if there is a posterior placenta like this, and when you see it, you feel, oh, I can enter, you know. But if there is any change in this, for example, if the bladder becomes full, typically when you make her lie down, paint, drape, bladder may become full, and then this placenta will go further away as the uterus tilts back. Or if you use a lot of pressure of the probe, what will happen is that because this is depressed, you will feel that there is no gap over here. You know, you cannot afford to go here and pierce the amnion. Because of that increased pressure, you will get a false sense of reassurance that you are actually going to the placenta. So these are some of the small things which you have to be very careful about when you are doing, especially for posterior placenta, because you know that there is a negative pressure. So the moment you pierce this sac, all the amniotic fluid will be sucked, and then this is going to be a sure shot miscarriage. So you have to be very particular about these things when you are doing CVS. The other thing which you'll find is vaginal spotting is seen in 1/3 of the women, but this is more in cases of those which are done by trans-cervical approach. When we do it by trans-abdominal, we hardly ever get any spotting in these patients. And you can give them tranexamic acid, it might be helpful, it usually settles on its own. Then we already spoke about limb reduction defects and oromandibular hypogenesis. This is not because you are actually sucking out the limb, but it's because it causes some vascular injury when it is done at an earlier stage, and therefore you'll find these reduction defects. So we don't do them anyway, we don't do them before we have done a good NT scan. So now this is obviously we always do it after 11 weeks. Chromosomal abnormalities may be present in the extra-amniotic tissue which are not found in the fetal tissue, so you have to be careful in interpreting the reports. One example was given by Dr. Vandana. Intrauterine infection or chorioamnionitis can occur if you have not used the proper precautions, membrane rupture and fetal loss. When it comes to amniocentesis, again you have to check the position of the placenta very carefully. You can just go all over and see where the placenta is ending, where you are getting a good pocket. Look at the cord insertion. Sometimes the cord insertion can be at the very edge or even velamentous cord insertion. So now we have Doppler on all our machines, so it's a good idea to put on the Doppler and check where is the cord. Even if you're seeing a nice pocket, don't be in a hurry and just go and put the needle over there. You look at the number of fetuses, gestational age, viability, document the anatomy, locate. So everything, a good scan has to be done first, and try and be away from the placenta as much as possible and away from the fetal face also. So if you have two good pockets and one is on the side of the head and the other is on the side of the buttocks, you will always go on the side of the buttocks, because the baby might move when you are doing the procedure and you don't want to injure the eye of the baby. Then the precautions, the mother is told to rest for some time in left lateral position, strenuous exercise not to be done. Nowadays women want to immediately join back work. I have one patient who has os tightening done, cervix is very short, and she is so concerned about that 10th standard exam and the invigilation. All the time she is thinking of that IVF pregnancy. So people are so conscious, you have to really tell them that to take care. So earlier it was the other way around. We used to tell them you can do all your normal activities, but now we have to see what is their perspective. Sexual intercourse to be avoided for 24 to 48 hours, and report if any fever, vaginal bleeding, fluid leakage, uterine cramping, anything happens, you tell her immediately contact and get advice. So complications may be higher in the presence of first trimester bleeding. Sometimes there's been a subchorionic bleed. Often it may be asymptomatic, it was just reported by the sonologist, but one has to be careful with these people. If it's a large bleed, one would probably not do the CVS, but wait for it to be resolved and do the amniocentesis. Ultrasound demonstration of chorioamniotic separation, discolored fluid at the time of procedure, one was shown by Vandana. Or an unexplained elevation in MS-AFP, which we don't really do routinely nowadays. Now coming to amniocentesis, how to identify the problems with the sample. Now when we take the sample, we try and discard the initial 1 or 2 ml to avoid the maternal contamination. Look at the color of the fluid. If it's bloody, then usually the blood is maternal in origin, so you are worried that there will be MCC. You may change and ask, of course they will give you a report of the maternal cell contamination, but you will probably want to do a chromosomal microarray and not a karyotype in this case. You will always do a FISH, because FISH will give you the report. You can also check, this is more for chordocentesis. We can check the RBCs and see the volume of the RBCs by running it through a Coulter counter, and fetal RBCs are always larger than adult RBCs. This is meant for chordo, not for amniocentesis. Dark red, brown or wine colored early intraamniotic bleeding is indicated if you get this kind of color, and these are at a higher chances of not only failure of culture but also loss in about almost up to 1/3 of the pregnancies. In later gestations, greenish color or greenish brown may indicate meconium. Another problem you can have during amniocentesis is that if you are going in slowly, if you are hesitating too much and you are stopping when you have gone through the abdominal wall, you don't pierce the amnion but you lift it, which is known as tenting, like this. Now the problem with this is that it separates from here, and you have done the amniocentesis successfully, but through that tiny hole the fluid leaks over here and then gradually comes from the side, and then patient will complain of leaking. So you try and do it in one prick as far as possible, through and through. So post-procedure leak, the management is always conservative, bed rest, tocolysis, antibiotics. Usually it settles in a few days because there's no infection. In a spontaneous leak, usually there is infection, the membranes have become soft, etc. Those factors are not there. It's just a tiny hole with your fine needle, so it usually settles down. The other thing is your assistant is also very important. Suppose, you know, in some of these patients, you can't really see this membrane, it's very thin. So especially if the patient is obese or there's some patient factors, you may not be able to see that you have tented it. What happens is when the person is trying to aspirate, nothing is coming. So you must tell them immediately stop. If they go on applying pressure, that membrane is going to get sucked up into this and cause a tear in the amnion. So your assistant also has to be educated. The other thing they do is, you know, when you put the membrane, when you're taking out the stillet, it should be straight up. They have a tendency to rotate it. So when you're inserting the stillet, you have to rotate, but when you're pulling it out, you should just pull it out straight. At that time, again, if the assistant does a screwing motion, you'll increase the hole. So these are very small things, but they could lead to a loss at the time of amniocentesis. So earlier there was a concern that there is much more loss with CVS, but now it has been proved that in good hands, if the procedure is done properly, CVS in fact can be safer than amniocentesis, and the two results are almost comparable. Again, I talked about RH isoimmunization because CVS extracts placental tissue, which causes a little higher risk of feto-maternal bleed, mixing of maternal and fetal blood compared to amniocentesis. Amniocentesis may be a safer procedure in RH incompatible pregnancies. So some special situations, one is early amniocentesis. So you can see over here that the amnion and chorion are still separated, and therefore the risk is little higher in these people of loss, ranging from 2.2 to 4.8%. Personally, I do it exactly at 17 weeks. I don't even do it at 15 and 16. So increased fetal losses, oligohydramnios, Talipes equinovirus, probably as a result of oligohydramnios. So this is not recommended over CVS. Either you do a CVS at around 13-14 weeks, or you wait 1 or 2 weeks extra and then do the amniocentesis. Nowadays we are getting patients with morbid obesity, which was not there in the past, and especially they have a lot of fat on the tummy area. So here what can you do? Sometimes you are really not able to see. You have some machine settings for obese patients. You can adjust that, you adjust your focus, everything, and see if you will be able to do it. Otherwise you may want to do a amniocentesis because you can use a longer needle. Then fibroids also are present sometimes. We avoid going through fibroid. The fibroid is going to be hard and you will not be able to penetrate. So you have to change the route slightly and see how you can avoid the fibroid. Again here in a CVS you hardly have any area. If there's a large fibroid, you wait for the uterus to grow and you may do an amniocentesis. Sometimes the patient may be HIV positive, hepatitis B or C positive. So what do you do in these instances? You do need to give them the chance to have the genetic testing. So if they are HIV positive, she should be given antiretroviral therapy, and you make sure that the viral load is undetectable. Then the chances of transmission will be minimized. And for hepatitis B and C, again you can consult your infectious disease specialist because the patient can be given some medicines and the viral load can be seen. Now coming to chordocentesis, this is a procedure we don't do very often unless it's a hematological disorder, or you have absolutely run out of time and you have done the other procedures and not got a report and you're looking for a blood disorder. So this has got little more complications, almost to the tune of 4 to 5%, where you can have all these various complications, bradycardia, which may be either due to spasm of the vessel if you've gone into an artery, or due to pressure from a hematoma in that area, or you can have cord hematoma, umbilical. When you withdraw the needle, it might start spurting. Usually you get a little bit of bleeding which looks like a snowstorm and all, and it stops. But you can get a spurting which will continue. Feto-maternal hemorrhage is more. You can have PPROM, preterm labor, and all these other complications. Maternal contamination of sample, as I told you, the size of the RBCs will tell us, and sometimes failure to obtain a sample. Now, I think twins she has covered very nicely. I just wanted to say that combination, you can do a combination of, this is the chorionicity testing, you can do combination of trans-cervical and abdominal to, if there is a posterior low-lying placenta. And looking at the cord insertions is also important, mapping is important. It's good to draw a diagram of how it was when you took the samples. Of course, you can keep the notes, the plates also, but it's good to draw that we took from here and this is A, this is B, so that when it comes back, you will know which one to reduce. Again, in twins, you can accidentally end up taking the amniotic fluid, both of them from the same sac, so you have to be careful about that. You should see that the membrane is clearly visible when you are taking the sample, on one on either side. Indigo carmine is said in books, but we don't really get it easily, and it's not necessary if you're careful about it. Fetal loss in twins can be slightly higher than in a singleton pregnancy, but this may be due to multiple factors, not simply the procedure. It may be because of elevated baseline risk of miscarriage already inherent to twin pregnancies, double insertion and prolongation of the procedure. Okay. Now, coming to the genetic test, sometimes you may not get an answer. In spite of doing all this, you may have a false negative. So, chromosomal microarray is a better test than a karyotype, which we already talked about. In patients with a normal karyotype also, you will find an extra abnormality in 6% of fetuses which have structural defects, especially if they have in multiple systems and in CNS. 5% of fetuses with increased NT, 1.7% with positive screening. So now karyotype has almost been replaced by chromosomal microarray unless you are looking for Down syndrome specifically. Repeat testing may be required in some instances. If the CVS shows mosaicism in 1 to 2% of the cases, this could be either confined placental mosaicism or true mosaicism. So, most usually in 90% of the cases it will be a confined placental mosaicism and we will be ruled out by doing an amniocentesis. Failure of getting a report is less than 1% or maybe even less than that now because we do not need to culture it. Sometimes in twins what we do is, if we have diagnosed the anomaly a bit late, around 20, 22 or 24 weeks, then you don't want to do the reduction at that time because the other baby might, in a miscarriage you will lose the other baby. So, you can do it late at around 32 weeks after giving steroids. So, in those cases again, if there is a twin switch phenomenon or the positions are completely different, you may want to confirm by repeating the amniocentesis, especially if there is no structural anomaly, if it is a genetic anomaly. If it is a structural anomaly, you can identify which twin it is, but if there is nothing like that, then sometimes you have to repeat for that purpose. So, to minimize losses, you need an experienced operator, at least 30 procedures under supervision before you start doing the procedures, and you maintain your skill by doing at least 30 procedures per annum according to RCOG. Always use sterile and safe practices, and if you feel that it is becoming difficult for whatever reason, just stop there and tell her we will do it on another day or we will replace it with amniocentesis, because you don't, it's not a problem of your ego that you have to do it or something like that. What are you looking at? You are looking at maximum safety, so you can defer it and do it on another day. So, pre and post procedure counseling is most important, and this should be documented with the couple's signatures preferably and your signature, so that, and then it goes with the patient. So, you take a photo, you scan it and keep it with you. And do a lot of practice. I think this kind of simulators is very good for all of you because you can do it multiple times in a relaxed environment before you are going to do it on the patient. Initially you can assist somebody who is doing it because you will come across so many different situations. You will have patients who are having a genetic problem and oligohydramnios, there is hardly any like. And the placenta is covering everything except for one corner somewhere, then you turn her on one side, you try to get a good pocket and you take that. So, there are so many small things which you can learn by guiding, by assisting senior people. And initially somebody may help you with your procedure, so you can call them when you start doing on your own. Most important is to remember is primum nor norcia, do no harm when you are doing these procedures. Thank you very much.
Thank you, ma'am. It was very nicely explained.
We would like to welcome the next speaker for the day, Dr. Bela Bhatt ma'am. She is consultant Dr. Bela Women's Hospital and Fetal Medicine Center, Mumbai, Vice President-elect FOXY 2027, Chairperson FOXY Imaging Scientific Committee, FOXY and ICOG certified trainer of ultrasound and obstetrics and gynecology, multiple achievements to her tag. Please welcome Dr. Bela Bhatt ma'am. Over to you, ma'am.
At the outset, I'm extremely thankful to my own AFG family, President Dr. Anurag Bhate, the convener Dr. Raju Saitya, for giving me this opportunity to present in front of all my seniors about the various cases related to invasive diagnostic techniques. Well, with two wonderful talks by Dr. Vandana Bansal and Dr. Purnima, we already have a strong foundation about the understanding of these invasive procedures, that is amniocentesis and CVS, and I am going to pick them top. And I am just directly going to discuss about various cases of these diagnostic invasive procedures, and that will definitely help even this one. Yeah. For every obstetrician also it's important. It's not that those who are doing these invasive techniques it's important. It's important for every obstetrician to understand, because we have to, as Dr. Vandana Bansal mentioned, that before the procedure, the counseling is extremely important. Patient has to understand as to what test will be offered, what will be the result, what will be the action after that. And so we must know that the aim of any prenatal diagnostic technique is to not to generate perfect babies, but to give information to the parents about the health of the unborn child and help them make informed decision. It's not always about termination of pregnancy. So as this gentleman, this physician mentioned long back, let the young and every one of us know that there were a more interesting, more infrastructure or book than the patient himself, and therefore we are going to discuss about the various cases. So I'll start with some of the common chromosomal problems, and then we'll go on to discuss about some complex genetic conditions as well. So this 37 years old non-consanguineous marriage, primigravida, conceived with primary infertility 7 years with IUI, had nuchal scan, showed NB present. Patient had anomaly scan done, which showed unossified nasal bone, was referred to me for second opinion about the nasal bone. And this was the picture. So this is a clear cut unossified nasal bone, as you can see very well here. And therefore, not only that, patient also had one more marker, mild hydronephrosis or pilectasis. So patient was counseled based on this, that with these markers, the risk for trisomy 21 is very high. So typically what we offer to this patient is amniocentesis, followed by first FISH to rule out trisomy 21, 18, 13. And if that is positive, we always usually try and do karyotype to try and find out the type of trisomy 21, and the FISH was positive for trisomy 21, and the karyotype also confirmed the same. So that was, this is trisomy 21, as we all know, is one of the commonest chromosomal problem. Another case, 23 years old, non-consanguineous marriage, primigravida 12 weeks. Now, here there is cystic hygroma. As you can see, there is subcutaneous edema all around, but what is important is the thickness. As we all know, even cystic hygroma, what is important is the the measurement of the nuchal translucency, and that was way beyond 99 centile. However, so we always look at the structures as well, because there can be some structural defects which would increase the chance of genetic syndromes. So structurally fetus looked okay, the cardia looked okay, and the CVS was performed, and on the CVS it did show pathogenic, that was trisomy 18. So this was a case of trisomy 18 with again on chromosome 18 microarray which showed trisomy 18. And so these are two common conditions we have discussed about, which are 21 and 18. Now this is another common structural defect, that is 26 years old non-consanguineous marriage, primary gravida 19 weeks, which showed, baby showed CTV, congenital talipes equinovarus. As you can see with the long bone, you can see the entire foot. So that is suggestive of CTV, and the other leg was normal. Okay. So this was an isolated anomaly, meaning that there was no other structural defect, there was no other marker in this particular fetus. Okay. So patient was counseled that even with isolated CTEV, it's important that we counsel the patient that we need to rule out chromosomal problems. Sometimes there can be some genetic condition or syndrome, and therefore amniocentesis was performed. However, the microarray did not show any defect. Now we know that the CTV is something which is a correctable anomaly. So counseling here plays a very, very important role, and we have to counsel to the patient that we'll do antenatal orthopedician's opinion will take, and most of the CTVs without genetic cause can be corrected with physiotherapy issues, or sometimes surgery may be required. Patient did get the opinion and then continued the pregnancy and delivered, and came with this baby at 1.5 years of age with just physiotherapy and shoes, without any need for surgery. The baby was walking well at the age of 1.5 years. So there comes the importance of counseling, that this is something which is correctable, so please do not terminate this fetus. Now this was about some of the common chromosomal problems. What about single gene disorders? So as far as single gene disorders, it's extremely important that before you offer the CVS, you have already done a good homework, preferably pre-pregnancy or in the early pregnancy. So there are various single gene disorders in which there are autosomal recessive, autosomal dominant, and other conditions. I'll just take very common beta thalassemia to give example of it. Now beta thalassemia, we know that when you get your HPLC done, it will tell you that the parents are carriers. So if the patient is carrier, you have to obviously test the husband. And because HPLC is going to tell us, and then thalassemia we know is autosomal recessive condition. So if both the parents are carrier, every pregnancy 25% chance will be that there will be thalassemia major. But lab diagnosis, that is HPLC diagnosing thalassemia, is not equal to the genetic diagnosis. So you have to do genetic diagnosis, and then genetic diagnosis will tell you what genetic mutation it is, because in beta thalassemia also there are so many variant of mutations. So you have to find out which particular mutation this couple is carrying, and then you have to test the fetus. So I'll just take you to this, and then you do CVS for the same mutation to find out if the fetus is affected. So this one, 28 years old, primary gravida, came to me at 10 weeks of pregnancy. Now this is the problem. Patients come, they both were thalassemia minor, they knew, but the genetic testing was not done. They thought this is enough. Now we'll do CVS and we'll come to know whether baby is affected, right? That's not true. You may have diagnosis of HPLC or thalassemia carrier, but your genetic testing has to be done. So for me now the job was to find out what is the mutation in the parents, and then only I can test. So what was done? After nuchal scan, because she was close to 11 weeks, nuchal scan was done, CVS was done, and in that we did the parents and the fetal. We did trio testing. In fetus tested for the gene for mutation for thalassemia, and parents' blood was also taken, and as you can see, parents were carrier for beta thalassemia minor, particular gene mutation, and then the fetus was tested, and fetus was normal for beta thalassemia. So here we understood that the parents are carrier for this, but the the fetus is not affected. They continued the pregnancy and the baby is normal 4 years old now. Now we come to little complex genetic conditions. 30 years old, non-consecutive marriage. There was a history of affected child on maternal side. There was some neuromuscular disorder in the baby. This patient was third gravida. First full-term male died in 15 minutes. No papers available. This little old case in 2018-19. Second full-term delivery, female died after 4 days, suspected having arthrogryposis. Just one report which was showing suspected having arthrogryposis. And third, referred at 18 weeks. Now on ultrasound, these were the pictures. So as you can see, they were fixed extension in the upper limb and fixed flexion deformity in the upper limb, and lower limb there was fixed extension. So you can see this was typical throughout the half an hour examination, this condition. So we definitely know there is some neuromuscular genetic condition which is affecting, and there was previous history which was correlating with this. Thus there is a very high chance that this is a genetic condition. Now this patient was referred to me from a government hospital. So patient went back to the government hospital, and it was counseled to the patient that this time, at least in the previous two, the genetic testing of the baby was not done. So what is important is to find out the mutation in the baby. So obviously they would terminate this baby. So it was told that fetus is exome sequencing along with parental. So trio exome sequencing is what is extremely important to be done. There were additional findings also in this baby, like cerebellar hypoplasia and high nuchal fold thickness, and patient then went back to the government office hospital, terminated. This was the abortus photo and X-ray which was taken there, and this time they did get trio exome sequencing, and as you can see, there was a cozy related disease, and the proband, that means the fetus, was homozygous, that means affected with the same, and the parents were heterozygous, that means they were carrier for the same mutation. So now we have got the link that previous to this is the third pregnancy and the fetus is affected with this genetic condition. In the fourth pregnancy, they came to me right from early pregnancy at 12 weeks after nuchal scan, coronary sampling was done, and this time fortunately the baby, the baby did not, fetus did not show the correlated disease, and on ultrasound also baby was looking normal. They continued the pregnancy and delivered a term of female of 2.5 kgs in the fourth pregnancy. But here the best part was we had genetic mutation in hand, so we could do CVS and rule out genetic condition, and therefore they were reassured, continued. So that's the importance of doing workup before pregnancy or very early in the pregnancy, better before pregnancy. Another very, very interesting case, because here it was in error of metabolism. 25 years, consanguineous couple, second gravida, first LSCS, male of 2 years. Now, they gave the history, patient came to me in early pregnancy, gave history that my first baby had lots of complications, septicemia and so much, and they were in Gujarat, they came to Mumbai, some good neonatal setup, and there it was at the end of 15-20 days it was diagnosed that baby had galactosemia, and they could with great difficulty they could save that first baby. So they said we want to see to it that this baby is not affected. Now again they had a pile of papers which were showing galactosemia, report this, that is, but there was no genetic test which was done in the baby. So first thing for me to do was to find out what genetic mutation the fetus is carrying. So 2 years baby, genetic testing, blood was sent to the genetic lab to find out the mutation for this, and it did show the pathogenic homozygous in the fetus. That means we got the mutation in the proband or the baby. Now once you find the mutation, again many of the times the obstetrician asks me, so mutation is found, so we can go ahead and do the CVS. No, we can't do that. We have to first establish the same mutation, the parents are carrier. Because if the parents are not carrier, then there won't be chance of recurrence. Sometimes these are de novo mutations. In that case, there will be no chance of recurrence. So we have to test parents for the same mutation. Parents were tested and they were heterozygous for the same, so they were carrier. Now we have established ring. So in next pregnancy, I have to go ahead and do the CVS to find out whether that fetus, because autosomal recessive, every pregnancy there will be 25% chance of carrying this particular galactosemia. So this pregnancy, CVS was done and fetus had the mutation, but it was heterozygous. So that means the fetus was carrier just like the parents, but were not affected, but was not affected. So a carrier fetus, they wanted to continue, they continued and delivered with me section 2.6 kg female, that was normal. Now, postnatally also I confirmed with this newborn screening and it proved that there is no galactosemia. Okay, baby was just carrier. Now, this was about second pregnancy. This patient had previous to section, one affected baby, one carrier, they wanted to go for third baby as well. I said again you'll have to undergo CVS because every pregnancy carries 25% chance. They said we want it. Third one, again they go ahead do, but the third baby was not even carrier, normal on CVS. So this is the photo that the of all the three children. The first was having affected, second carrier, and the third normal. I hate to put these labels here, but it's an academic discussion. Otherwise, they are very, very lovely children. But so this is how we are going to help the family and parents find out during pregnancy. As I said, we give information about the unborn child and then let them take decision what they want to do. And the last but not the least, this is a very, very interesting case. 38 years old female, couple came for removal of copper T. She was gravida 3, para 3, all full-term normal deliveries, one son, 2 daughters. First daughter, 15 years, was absolutely normal. One son and one daughter were deaf. So they wanted, before pregnancy, they came and said, Madam, 2 kids are deaf, can we do something so that the next child is not deaf? Now again, deafness does not always have genetic cause, but it does have genetic cause. So we need to first find out. So let's start from here. So when I looked at the mother, the 38 years old mother had characteristic features. She had brown colored iris, unusual wide nasal bridge, white forelock. So I asked, is it recent? She said, no, since birth I have this white forelock, which is abnormal. Then I said, do you have your pictures of your kids? So the male, which was affected elder son, had hearing loss, both grey eyes, white forelock, again since birth, which is abnormal, right? So we know we are getting some link towards genetic cause. 7 years old, which has severe hearing loss, one grey, one brown iris, white forelock. This was the birth photo of that baby. Can you see this white forelock? Which is abnormal at birth. And this is current photo of 7 years old. So all the features matching in the mother and 2 deaf kids. So now the genetic consultation was done and geneticists said there is a very high chance these babies are affected by Waardenburg syndrome, which is a genetic syndrome. Now patient was counseled. Step 1, as I said, when you suspect something, you have to find out the mutation. So the more affected daughter's blood was taken and it was sent to find out if there is a mutation, and it did show pathogenic mutation for Waardenburg syndrome. This took 6 weeks. It takes 6 weeks for whole exome sequencing, and that's why I keep repeating, please do this workup before planning next pregnancy, because you will lose your golden time otherwise before CVS. Then, as I said, we have to establish the link. Mothers had all phenotype, but then you have to find out whether mother is a carrier. So mother's blood was sent and it did show that she's a heterozygous. So she's carrier of this particular Waardenburg syndrome, and that's why both the son and boy and girl had Waardenburg syndrome. Now the counseling was done that Waardenburg syndrome is an autosomal dominant disorder. So in every pregnancy there will be 50% chance of affected child. Are you ready for that? Now again the expression is different. Some may have less deafness. Mother didn't have deafness, but one had severe deafness, one had less deafness. So expression, phenotype, genotype is little complex subject, but it will be affected. So they had option number 1, go ahead, do CVS, find out mutation, or go for donor ovum IVF because mother is affected, or PGT followed by IVF. They said nothing doing, we'll go for natural pregnancy and CVS. Now the copper T was removed. Now after all this workup, which took 10 weeks, then copper T was removed. Fourth pregnancy, 12 weeks, after low risk nuchal scan, CVS was done, and this fetus fortunately again did not show Waardenburg syndrome, so they continued the pregnancy, and this was on birth. First thing I looked for white forelock, of course that's not the only thing, and this was normal hearing, now almost 4 years old, normal hearing, no, not affected by Waardenburg syndrome. Now what is important in this particular case is that all this genetic workup took 10 weeks, 6 weeks in the proband and then 4 weeks to establish in the parent, 10 weeks. So you can't do all this in pregnancy. If you send it 10 weeks for CVS or 12 weeks for CVS, we'll lose 8 weeks, and by 20 weeks we'll have the diagnosis in hand, right? So this has to be done before planning pregnancy. We have suspicion, where you have suspicion of some genetic condition, and then this, because it was done pre-pregnancy, we could very well manage and then continued till delivery. So as we all know, whenever we are dealing with these patients, there are a lot of genetic, this is so complex even for us obstetricians to understand. Genetics is very, very complex, and for patients it is all the more difficult, and when they have such hearing loss, some other genetic syndrome and all, of course they'll need our empathetic approach, and so let's ensure our loyalty to science is always less than that of our patients, and compassion is something which always we should combine with science to treat our patients, and kindness and compassion can heal those wounds more than medicine can. So with this approach, I'm sure we'll be able to help our patients, and I hope that with this case discussion, we know how to use it in daily practice. Thank you so much for patient hearing. Thank you.
Thank you, ma'am, for showing so many different cases to us.
Any questions from the audience?
Because mother had characteristic phenotype. She had colored iris, white forelock since birth, white. So it was matching with the Waardenburg syndrome. The father didn't show any phenotype. So phenotype, genotype, because it was matching with Waardenburg, mother was tested in this particular case. Okay. Yeah. Thank you.
A big thank you to our speakers for such fantastic talks, and a big thank you to our chairpersons for being here today with us. I would now request our President, Dr. Anurag Bhate, our Secretary, Dr. Jayanti Kamath Madam, and our convener, Dr. Raju Sahitya Sir, Dr. Rupali Dharwarkar, and Sarogi Sir, to please join us in felicitation of our speakers and our chairpersons. Please join us. Please join us.
No, I thought the panel has started.
Purnima ma'am. Dr. Bela Bhatt ma'am. and our chairpersons, Dr. Shalini Agarwal and Dr. Saurabh Surekha.